Welcome to our first Best HIV Regimen for Children webinar. This is our first 8 o'clock in the morning SAPA webinar. My name is Mignon McCulloch. I'm on the SAPA executive and I'm also a pediatrician based at the Red Cross Children's Hospital. I'm fortunate enough to be co-chairing with James Nuttall, who is a pediatric infectious disease specialist also at the Red Cross Children's Hospital. And James, I'm going to hand over to you to explain how this webinar all came about.
Thanks, Mignon, and good morning, everybody. I hope people have been able to join either through this Zoom link or through the YouTube link. And it's a great pleasure to co-chair this session together with Mignon. I'd like to pay credit to Dr. Martie Virge, who through the South African Pediatric Association came up with this vision of what she called a national groundbreaking grand round, particularly focused on the topic of HIV in young children and changes to the guidelines, which are imminent, in progress, and about to hit the clinics and the wards, and a way to try and get the message out about new regimens and changes to the guidelines that we hope will be helpful and useful for everybody. So HIV Clinician Society is co-hosting this. The Southern African Society for Pediatric Infectious Diseases is present. We look forward to a great discussion. 3 talks. Speakers will be introduced sequentially. Questions will be posed in the chat or Q&A, not live. And there will be a follow-up session this evening between 5 to 6 p.m. where some of the particular case scenarios will be addressed and questions that we don't get to today. So please do consider rejoining that session if you can. Our first speaker will be introduced by Mignon, Professor Mo Archery. So I'll hand back to Mignon for that. Thanks, Mignon.
Thank you for that, James. And so, as James said, if you are missing this or you know of people missing this, please don't forget to join us again at 5 p.m. this evening. It's a BD regimen, the SAPA webinar today. So our first speaker, we're very privileged to have Professor Mo Archery. He's a pediatric infectious disease specialist at King Edward VII Hospital, also attached to the University of KZN. And he's the vice chair of the Treatment Scientific Committee in Impact. He's also the chair of the Pediatric and Adolescent Committee in the South African HIV Clinician Society. And his research interests include antiretroviral drug therapeutics, viral resistance, and optimal timing of initiation. So before you all take a deep sigh and say, why do we need to change the guidelines again? I'm hoping that Mo will have convinced you by the end of his talk. Thank you very much, Mo.
Thank you, and thanks. I think it's really great to be part of this webinar, and I think it's really one way in which we can get together as a pediatric community across the country and bring our organizations and universities together. So I'll start the ball rolling, and really every time I ever mention that there's a change in the guideline, there's usually a huge sigh as to why do we need to change the guideline again. We just got used to the previous guideline and now we've changed it. And certainly I think the last guideline was in 2019. We do find ourselves in a completely different space from where we were, almost 4 years ago. COVID has been there, and there's been major changes, but also there's been major improvements, and we've had newer regimens, newer drugs, newer formulations that really will impact greatly in terms of improving the access to treatment, and also we hope to have an improvement in terms of the response to treatment. So I'll go through some of those changes and really also celebrate the kind of improvements we've had in terms of the antiretroviral program for both mothers and children. So if you look at the pediatric HIV landscape in 2022, 2023, we've had this dramatic decrease in terms of the incidence rates. However, there's still approximately about 160,000 newly infected children living with diagnosed with HIV. And that results in around almost 100,000 AIDS-related deaths in children, and there's a huge number of children living with HIV worldwide. And you can see almost half of that live in Eastern and Southern Africa, so approximately 50%. If you go to South Africa, Again, children account for about 12,000 new infections a year, and this was data from the UNAIDS in 2020. Again, adolescents is another huge topic in terms of the numbers, with about 40,000 newly infected adolescents. And that does pale in comparison to the total cohort, but still is a significant burden in terms of the lifelong need for antiretroviral treatment and care for these children and adolescents. So the numbers we have in South Africa is about 310,000 children living with HIV and about 370,000 adolescents living with HIV. So one of the major things that we speak about is really around closing the tap, and closing the tap is really around decreasing the number of new infections, new HIV infections. And we always spoke about elimination of mother-to-child transmission, and Elena will go through this change in nomenclature to really talk about vertical HIV transmission. So the WHO has these part 2 elimination to validation, and that goes from bronze to silver to gold, and a full validation in terms of elimination of vertical transmission. And Botswana has become the first high burden country to achieve silver status in terms of elimination of vertical transmission. So what does it need? What do you need to get to this vertical, this elimination goal? And the one is, high levels of antiretroviral coverage. You need to have low transmission rates and certainly less than 5%. And more importantly, you need to have, in terms of your infection rates, in terms of your case rates, need to be low. And if you look at South Africa, certainly our maternal testing and ART coverage, if we look at our overall, is quite high, and it's unbelievably sitting at 106%, but probably is around 90-95%, and certainly meets the criteria for full validation. However, if you look at our case rates, we have a number of new HIV infections in children of around 1,290 cases per 100,000 live births. And if you look at to reach the goal of elimination, you need to bring it down to less than 50. So we're far lower than, far higher than what we would expect it to be. And our vertical HIV transmission rates are relatively low. So again, at 6 weeks, it's at 1.7%, and at 18 months, about 4.3%. And again, it does meet the criteria for full validation of elimination of mother-to-child transmission. And really, I think the main area that we need to focus on is trying to decrease the case rates. And that really speaks to the burden in terms of the number of women living with HIV, and also the number of women who are at risk of HIV transmission. So if you look at overall in terms of ART coverage in pregnant women, so we've had quite a dramatic increase in ART coverage, but it's remained relatively static since 2014. And certainly we need to do something more in terms of increasing coverage, but also going one step further in terms of patients, pregnant women being on antiretroviral treatment, but also remaining on treatment and remaining engaged in care, but also maintaining virological suppression throughout their pregnancy and pre-pregnancy. And that's something that we do need to highlight and work towards. And this has resulted in a minimal decline in new pediatric infections. So you can see, between 2010 and 2015, there was a steady decline in terms of new HIV infections in children. However, that's kind of settled down, and we haven't had major impacts in it. So there's been really no change, or around 10,000 decline in terms of new infections per year. And looking at that, if will take us another 14 years, which means 2035 to meet our 2020 target, which was to reach a target of 20,000 new infections per year. So we really need to pick up the pace and decrease new pediatric infections. So if you look at what's causing these new infections, mothers infected during pregnancy or breastfeeding accounts for about 22%. 45%, 48% is really around mothers not on antiretroviral treatment, predominantly between pregnancy or in our setting a lot also during breastfeeding. And I think the testing and early starting of treatment is an important avenue that we need to explore. And then mothers not continuing treatment during pregnancy and breastfeeding account for 22%. And then 8% is mothers not biologically suppressed. These are global targets, and certainly there's some regional differences across the world in terms of those proportions, but those are largely incident. And if you look at most of Southern and Eastern and Southern Africa, incident infections are probably the leading cause of vertical transmission, and certainly decreasing new HIV infections in pregnant women and their partners should be a priority in terms of decreasing new infections in children. If we look at the pediatric HIV cascade and really trying to achieve the 95, 95, 95 goals, you can see across the board between adults and children, we lag between the two. So if you look at our first goal, which is really around children knowing their HIV status, adults is 82%, in children is 58%. And early infant diagnosis has declined slightly overall, and we really need to up our progression in terms of getting children diagnosed as early as possible and starting an antiretroviral treatment. The second aim is really around starting children on treatment. And again, you can see there's quite a big gap in terms of adults, and the global figure is 74% and 54% for children. And this is across the board, across multiple countries. And you can see South Africa somewhere in the middle there. And if you look at the total burden of children not on antiretroviral treatment, and on the figure on the left, certainly South Africa accounts for a large percentage of the global burden of children not on antiretroviral treatment. And if you look at the coverage, certainly the children under 5 have the lowest coverage, so around 40%. And then the second is adolescents as well. So really focusing on those young children and adolescents in terms of engaging in care, early diagnosis, and starting antiretroviral treatment. And similarly, ART coverage over time has not improved and been consistently lower between children and adolescents. And then the last one was really around biological suppression rates, and certainly the suppression rates in children and adolescents and in children are far lower, with around 40%. And this is, across the board, particularly in the very young children, where, as we all know, it's extremely difficult to maintain, adequate drug levels and make sure that they take the current formulation, which is extremely difficult and very to maintain and unpalatable. And the last, 95, or the fourth 95, is really around living healthy, a productive, and which is the goal of our program, is really having children who live healthily, have a productive life, and live a full life with HIV, and go on to be healthy, productive members of society. And this is, to speak to this, there's been a slow decline in deaths among young children. And we really, in terms of getting children on treatment early, maintaining biological suppression will go a long way in terms of decreasing this decrease in deaths. So if you look at South Africa, again, I think if you look at the data between adults and children across the board, we are, children fare poorer than adults. And if you look at the cascade, the adult cascade is 93, 78, and 89%, and children is 80, 59, and 63%. So really, and this is really looking at only children who had a viral load performed, and children less than 5 years of age are the most vulnerable in terms of poor biological suppression. So again, if you look at this figure in terms of biological suppression in children, certainly, children less than 5 have the lowest biological suppression, again, speaking to the difficulty with maintaining a lopinavir-ritonavir-based regimen, and we hope to change that in the new guideline. If you look at the biological suppression by provincial breakdown, I've just picked up KZN, which accounts for 30% of all children on antiretroviral treatment in the country. In KZN, the breakdown for children is 57%, while less than 50 copies per mole, which is going to be the new guideline in terms of biological suppression, 20% between 50 and 1,000, and 23% over 1,000 copies per mole. And the other thing I just wanted to mention is the difficulty in terms of viral loads done, and really we do need to pick up in terms of children who are on treatment and having their viral loads done. So lastly, I think where do we need to go? I think there's certain strategies to close the gap. We do need to eliminate vertical HIV transmission, preventing incident HIV infection, and that U equals U principles, PrEP for pregnant women and their partners, regular testing of pregnant and breastfeeding women, and early ART initiation, keeping people living with HIV engaged in care and virologically suppression, and certainly simpler, easier delivery mechanisms and regimens go a long way in terms of doing that. In terms of diagnosing, I think we have huge numbers of AID failures. We do very well with birth testing, and we just go downhill after that. So, 6 months and 18 months testing is extremely low, and we really do need to look at more active ways of testing and engaging these and getting them engaged in care. And really, emphasizing either community testing or testing at every healthcare interaction. And then maintaining adolescents in care is another area that we need to look at. So in terms of linkage of care, same-day start, and biological suppression in terms of maintaining children and adolescents engaged in care and biologically suppressed. So simpler, easier regimens, more palatable regimens that James will speak to is where we hope to be going with and improve our biological suppression rates in these vulnerable children. So in conclusion, I think we've made massive strides in terms of reducing numbers of new infections in children and preventing vertical transmission. There's further reductions. It's only possible by reducing new infections in adults and keeping people living with HIV engaged in care and biologically suppressed. What we've all seen is that these new infections occur in the most vulnerable part of our population, and we do require additional resources to ensure that they maintain in services and that we support them over this process. And new regimens, new, easier to use regimens will go a long way in terms of ensuring that it's easy for children and their families to maintain on this daily regimen of antiretroviral treatment. And lastly, I think this see no evil, hear no evil, speak no evil, in terms of our guidelines, it's always good to have great guidelines, but we do need to make sure that guidelines are turned into practice. And we need an accountable health system and a feedback in terms of, we all see every day of our lives when we're working, breaks in the system and where guidelines are not being followed. And we do need to make sure that there's an accountable health system and that we bring back making sure that people are aware of their positives and negatives, and we follow guidelines as far as possible. So I'll thank you, and I'll hand over back, I think, to James.
Hi there, Mo. Thank you. Handing back to me. I just want to say thank you for a great overview. You made it really practical. And I'm going to encourage the audience to type any questions either in the chat or in the Q&A, and we'll address this at the end of the session. But thank you very much for making it so practical. And I'm going to hand over to James to introduce the next speaker. Just some information, we are at maximum on our Zoom platform, 500 people, but can you just share with people the YouTube link? If you know of anybody who's struggling, it is in the chat group. Thank you, James, over to you.
Thanks very much, Mignon, and Mo for the first talk. The second talk will be given by Helena Rabi, who's a long-standing colleague. She's head of clinical unit at Tygerberg Academic Complex. She's a pediatric infectious disease specialist, as well as an associate professor there. She's a fantastic clinician who's very engaged with at the patient-doctor interface of how to achieve and improve patient outcomes and clinical interactions. And Vignon's going to, Helena is going to address the issue of what is FCVTP, which is a new term that we'll become accustomed to in the new guidelines. It's something to do with vertical transmission. So looking forward to this, Helena. Thanks very much.
Thank you, James. Helena's not awesome at Zoom, so I forgot how to switch the sound on. Thank you for inviting me to give this talk. I initially did see it as a form of punishment, because I was also thinking, what is it that we're talking about, and what is FCVTP? And I just want to also state up front that we are still waiting for the new guidance and the language that will come with that, but there is definitely a need for a language change. And I want to start off with this quote from Mark Twain, that the difference between the almost right word and the right word is a large matter. It's the difference between a lightning bug and lightning. And I think increasingly, as we are engaging with communities and with persons who we are caring for, the language that we use is increasingly important. So when we look at this in the context of HIV, the language that we use have been stigmatizing from the very first, where it was initially called grid, and children were involved in this, and mothers were involved in this right from the start, where really right from the beginning there were cases of children who received transfusion and who were born to parents with risk factors, and right from the beginning, transmission through breastfeeding was also documented. And the history of prevention is very long. The first studies were published already in 1993, and there's a long history of using prevention.
Can I quickly ask you not sharing your slides?
Yeah.
Are you not seeing the slides?
We're not seeing the slides, and also not your camera. I don't know if you want to switch on your camera or not.
Okay, can you see them now?
Not yet.
Let me unshare, because it's sharing on my screen, sorry.
If you struggle, I can also share from my side.
Can you see them now?
Still not?
No, it's not changing.
What's going on now? Sorry.
Do you maybe want to let Marty share?
Yeah, let Marty share. I just it's showing on my screen that it is sharing, Marty, so I might just have to unshare.
Okay, let me just quickly find that.
There we go.
Okay, now
Can you see that, Helena?
no. Let me check.
You want to try once more?
Yeah, let me see. I'm so sorry.
No, all good. No stress.
There
we go. Yeah,
thank you.
it's happening.
I'll start the camera while we're there.
Great.
Okay. Are you seeing?
We're seeing you. There we go. It's now in presenter. Presenter mode.
Better.
There we go. Perfect. Off you go. Well done.
So I just want to go back and say that, language around prevention is also really, and our history of our ability to prevent HIV in young infants and children is as long and as important as the HIV epidemic has been. And right from the start, persons who lived with HIV has engaged with the healthcare community about how we speak. And the first engagement around this was in 1983 already. And these were called the Denver Principles. And in the Denver Principles, persons living with HIV stated that they condemn attempts to be labeled as victims, a term which implies defeat, and they are only occasionally patients, a term that implies passivity, helplessness, and dependence on the care of others. And they don't want to be scapegoated and blamed for the epidemic, and they don't want to be judged and generalizations about their lifestyles to be made. And it seems that we really haven't listened to a large part. And we have to acknowledge as the healthcare community that words can acknowledge or marginalize, and words have value judgment. And so when we're talking about infection and number of infection and HIV infected, we imply corrupt, dirty, and tainted. And the community is asking us to use neutral words such as inquire or transmit. And there's a number of these words that, for instance, are associated with negative connotations. Even unsafe sex has a lot of implication, using the word drug addict, prostitute, and even as in the Denver principles I stated, victim and sufferer. These are all words that carry a large meaning and value judgment that we are often unaware of when we use them. And people are really at the center of the issue. And what is required is for us to understand that we need to describe what the person has and not what the person is. And to remember that the person should be placed in front and before the diagnosis. And that all of this should be done with respect, dignity, and understanding. And now, as we are moving into talking about persons living with HIV, what we are trying to acknowledge here is that we are talking about actual persons, not masses of people are being referred to. And in some contexts, even the abbreviation that we use can dull awareness. Living, using a positive word, and HIV, not AIDS, because HIV is the virus, AIDS is a clinical syndrome, and these words should not be used interchangeably. And as we are changing our language, we affirm and emphasize our shared humanity, and we acknowledge that our identities, just as the identities of all human beings, are nuanced, evolving, and layered. And when it now comes to this word PMTCT, in South Africa, we have a massive history of community engagement around the prevention of vertical transmission. And this I took from the TAC website, where you can actually see that right from the start, we were engaging and in activism around women who are pregnant and have HIV. And some of the most important litigation in this country coming from TAC was around this exact issue. And here we acknowledge the work that people have done. And now it is also time to understand what this word means. It means that there's an accusatory tone, the blaming of mothers for transmitting the virus. It's not conducive to male involvement. Elimination, even the word elimination, is problematic, as HIV may be very part of the identity of the person. There's a focus on an event rather than the person involved. And it really places the onus, the blame, the guilt for transmission and risk solely on the mother. And in this respect, when you speak to mothers, they actually consistently and over a number of years have mentioned that they find this term stigmatizing. And you can already see here in a letter to the editor in 2012 that the community is asking us for using a different term. The term they suggest is comprehensive prevention of vertical transmission. And they don't want us to stop, they want us to use stopping or ending rather than elimination. And there's a lot of internal and external stigma associated with these words. And still, there are physicians that express discomfort in working with persons living with HIV. There are definitely issues around race and phobia in countries where we are using, which are still working towards stigma. And I would like, if you can, for persons to visit these websites where you can actually hear the testimonies of persons living with HIV and how they feel stigmatized by the language we use in the healthcare system. When we're now talking about person first versus identity language, I'm certainly not an expert. And when you read the literature about this, what you realize is some communities do prefer identity first language. And in their opinion, person-first language diminishes them and may accentuate stigma. And there are examples of this. However, in the HIV community, there's a strong preference towards person-first language. And one of the explanations is that one, HIV is coming from outside the person. The other, maybe for instance, autism is integral to the person and into their way of being. And it's really important when we are thinking about the language we use that we consider the person in the community and their preference in how we address them. For those of us that are working in the academic sphere and want to write, the People First Charter is now guiding us as to language around HIV, and you can also look at that website where you can access the language preferences for persons living with HIV in academic writing. So we are now moving to this term where it's female and family-centered vertical transmission prevention, where we see women not simply as agents towards the health of their infant, and where the physical and mental well-being of the woman is as an important goal as the prevention of HIV acquisition in her infant. And we acknowledge the role of the intimate partner and the support of the family and the community. And in addition, in South Africa, there is a focus also on preventing other communicable infections with a focus on tuberculosis, HIV, hepatitis, and malaria, where we are looking at a comprehensive intervention during pregnancy and the early neonatal period to prevent transmitted illnesses. And if we achieve maternal health, we are going to achieve child health. So focusing on the mother and her health will achieve good child health. There's excellent evidence that maternal antiretrovirals prevents HIV transmission during pregnancy and breastfeeding. I don't need to remind any of us of that. But we know that women are acquiring HIV in pregnancy and during breastfeeding. And here is some information from KwaZulu-Natal, on the outskirts of Durban, where we can see how during pregnancy, women are acquiring both HIV and syphilis. And maternal syphilis, we understand, is associated with infant acquiring HIV, and co-infected infants are significantly more likely to be born to women who have higher VDRL titers. Viremia at the time of delivery is common, and here is some data on levels of viremia in women living with HIV in Gauteng. And viremia in the postpartum period is also common. And here you can see data from Cape Town with different interventions looking at viremia in the immediate postpartum period, where all women started with low viremia at birth. So when we look at why is this happening and whether women actually value the antiretroviral therapy, there's some very nice literature on this, where women are understanding and the reasons for antiretroviral therapy for themselves as well as for their baby. They have a desire to reduce vertical transmission and have a healthy baby. They're concerned about adverse effects of medication on the fetus and the baby. And they also do have desire for their own health, but they're experiencing adverse effects and they are complaining also about high burden. And in many settings, women are balancing these desired and undesired outcomes. And they are facing significant challenges, increasing risk of peripartum depression and adherence challenges in women who are pregnant and breastfeeding are very well described. There's a lot of guilt and stigma, and then also the health system is not conducive to care and navigating away from the midwife obstetric unit and to the antiretroviral services. So in the program, we are trying to address many of these components. Women living with HIV will have access to reflex testing for cryptococcal infection, routine assessment for tuberculosis. Hepatitis B screening will not be routine. There will be access to tuberculosis preventative therapy and viral loads at birth. And what is very important here is that there is enhanced viral load monitoring throughout pregnancy and breastfeeding to allow for this understanding that there is risk of viremia during these periods. However, it's important to notice that just taking these bloods but not acting and supporting women who are needing to take the medication is a futile act. We need to also act on these and support mothers for their own health, carry on with antiretroviral therapy. For women who do not have HIV, they will be retested for HIV to try to work through risk of HIV acquisition throughout breastfeeding, and they will be tested at least throughout every 3 months throughout breastfeeding. And there is also increased testing for syphilis every 3 months during pregnancy for these women planned in the new guidelines. So you can see, trying to have a more comprehensive approach, looking at acquisition of other diseases and that require us to address, and also trying to make sure that we support women to maintain low viral loads. If women have viremia, I think everybody is worried about resistance. So the viremia level now is 50. And if a woman has a viral load of 50, there's an intervention and a confirmation request at 4 weeks. And we are only going to consider resistance if you've been on TLD for at least 2 years and your viral load is more than 1,000 at least 2 occasions, and adherence is more than 80%. And why can we say this? Because if we were Harry Potter and we would have a Patronus, our Patronus would be TLD, where we know that this is an amazingly powerful drug and that resistance, even though it can happen, is extremely rare. So rather than concerning ourselves with what is resistance and whether we need resistance tests, we should focus on following up persons who have viral load more than 50 and supporting them with their adherence and struggles, and assisting them with managing side effects so that they are able to continue on a very powerful and effective intervention. But what are we going to do with the baby? So in the new guidance, all mums will get a delivery viral load, all infants will get a birth PCR. But what is a little bit different now is that all infants will initiate AZT and nevirapine. We will give AZT to everybody because it's easier to implement, and we sometimes see that infants don't come back. And if they then don't come back, they are covered and they will be managed as if their mothers have viremia. We think this may also strengthen the follow-up system messaging. And there will be some AZT wastage, around 6%. However, this is all in an effort to reduce the transmission to the baby. We have heard estimates that we may potentially avert an additional 500 new diagnoses in infants. However, I think this is very difficult to assess, and one would need to watch the implication of this guidance change. So all action will now be based on the maternal viral load at birth. So if you look here, you can see that if the mom has a viral load of less than 50 copies, regardless of whether she's breastfeeding or formula feeding, she will be issued, the mom will be issued with AZT nevirapine. And when the baby comes back, this result will be reviewed and the AZT will be stopped. Where mom has a viral load of more than 50 copies per ml, the AZT will still be stopped at 6 weeks, but the nevirapine will continue until 12 weeks, or the viral load of less than 50 copies is achieved. If the birth PCR is positive, we actually obviously will transition into therapy. And if the birth PCR is negative, the comprehensive prevention, monitoring and support of the baby should be done. There will be retesting at 6 months, 18 months, and 6 weeks after breastfeeding has stopped. There's one important additional change, and that is what we're not doing. And the cumulative evidence has shown us that cotrimoxazole for prevention in infants with in utero HIV exposure and a negative birth PCR is not needed and may indeed actually be associated with harm. So we are not starting babies with a negative PCR on cotrimoxazole preventative therapy any longer, regardless of their feeding choice. If mom develops viremia during breastfeeding, again, the concern is much less for resistance, but rather how do we support adherence? Can we address reasons for struggling to take medication? And if the infant has already stopped preventative therapy, we will reinitiate preventative therapy. And the question is, should you breastfeed? Yes, mostly, nearly always, yes. So most women should be able to breastfeed with our ability to achieve suppression with a TLD, and it would be rare circumstances that we would suggest that they do not require breastfeeding. Coming back to where we started with language, I would really like to thank Dr. Amy Slowgrove, who is a really advocate for mums and who's taught me a lot about what the community prefers and about person-first language. And I think maybe in a gentle way, we can shake the world and remember language is important. It's a firefly or it's a fire. Thanks very much.
Thank you very much, Helena, and thanks for getting the message across that the way we think and talk about vertical transmission is key. This is critical, and this is very inspirational for us to reconsider, and the guideline attempts to readdress this in how we move forward with vertical transmission prevention. Thanks. Shall I hand back to you?
Yeah, thank you very much. So it remains for me to introduce our last speaker, who's James, who's been co-chairing with me. He wears many hats and currently is the chair of SASPID, has lots of research interest in HIV. And from a practical point of view, James is part of an amazing infectious disease unit at Red Cross, who are always happy to put up with my strange and very odd questions sometimes. So thank you very much for that, James, and looking forward to your talk on a matter of taste, improving and simplifying ARVs for young children. Just to remind everybody, if we don't get to Q&A, please join us again at 5 o'clock this evening. But over to you, James. Thanks a lot.
Thanks so much, Manyan, for that kind introduction. And the previous two talks have really set a scene, I think, for this very thematic talk, which is directed at people working with children with HIV, living with HIV, who are either needing to start antiretroviral therapy or who are on antiretroviral therapy, and we're looking at improving the regimen that they're on. So I'm involved in guidelines committees. It's both provincially and nationally, and I see my aim as someone who translates evidence into practical guidance for clinicians. So the outline will be to focus on better ARV drugs and formulations for young children in particular, very young children, focusing on two key formulation changes or improvements that we now are having access to, or we're on the cusp of having access to. One being the scored dispersible tablets of bacavir 3TC, bacavir lamivudine combination, and dolutegravir, also a scored dispersible tablet. In addition, we have registration of an incredible combination 4-in-1 formulation, which is a bacavir lamivudine lopinavir ritonavir in a powder formulation within a capsule, which has a sort of powder formulation of granules that can be dispersed in water or soft food, and this will become apparent where this may play a role in our regimens where we still have to use lopinavir or tenofovir. So just to remember that there are children who are starting antiretrovirals, and then there are children, many of them, on antiretrovirals and are going to be remaining on these drugs and these medications, but how do we make life easier for them and their caregivers? And then back to the community that taught us about treatment literacy, the treatment action campaign, and how do we create demand for better treatment, both amongst doctors, pharmacists, and clinicians. So just some thoughts about that. Mo's given us the numbers, and this is just to reinforce the fact that there are new HIV infections, but there are many children living with HIV. So it's on both of those fronts that we're having to address these treatment improvements. And this slide that you've seen already of relevance to my discussion here is the issue of people living with HIV who are virally suppressed. And you can see children globally, 40% versus adults, 67%. And part of the aim with these new formulations is really to get parity and equity for children in hopefully being able to achieve similar or better viral suppression through the use of being able to adhere to better formulations. These are the documents that we hold dear and try to align and improve. This is the Advanced Stage 2023 ART Clinical Guideline for South Africa. It's due for release in the next few weeks, hopefully. There's still final refinements taking place. Then there's the standard treatment guidelines, both for primary healthcare level and for hospital level pediatrics. These are being updated chapter by chapter, at least for the hospital level pediatrics, and then the standard treatment guideline primary care level that's used widely at clinic and district hospital level. And it's quite challenging aligning these and keeping them up to date, but great credit to the teams that do this. So just a slightly hazy view of the real high level view of regimens in the new guidelines. So I hope you can see that. But at the top there, all adult and adolescent, both females and males. Remember previously there were concerns about dolutegravir among pregnant women. That's fallen away now. But if you're more than 30 kilograms and more than 10 years of age, you should have a very good reason for not being on the combination 3-in-1 tablet once a day of tenofovir plus lamivudine plus dolutegravir. As always, pediatrics isn't as easy as that. And if you look in the lower half of this slide, you'll see that for neonates, infants and children between 0 to 10 years of age, we still have 3 sort of sequences of, well, 2, but then leading on to the adult regimen. So in the neonatal group, from birth to less than 4 weeks of age, we're unfortunately still stuck with our slightly perhaps inferior, but workhorse regimen of zidovudine, lamivudine, and nevirapine. And we have guidance on that both from 2 kilograms at 35 weeks gestational age, but also less than 2 kilograms and less than 35 weeks gestational age. I'll come on the next slide to that. We don't have big changes in that arena at this stage, although there's a lot of research going on in terms of using some of the newer drugs in that neonatal period. And then from 4 weeks of age and 3 kilograms, as you can see on this slide, our go-to regimen, both for initiation, but also for hopefully switching many children, will be the combination of abacavir, lamivudine, and dolutegravir. And I'll come to the specifics of how we're going to deliver that. And then, as mentioned, from 30 kilograms and 10 years, the transition to TLD. And very importantly, these transitions do not require a viral load before switching. So they're based on age and weight criteria for that switch. This is just a slide to show you one of the algorithms for neonates using zidovudine, lamivudine, and nevirapine. This is the one for the greater than 2 kilograms birth weight and more than 35 weeks gestational age at birth. And you can see that we're still stuck with 3 separate liquid formulations and then some weight band dosing twice a day for those particular regimens in the neonatal period, before they can transition to probably what are more effective, potent regimens once they're more than 4 weeks and 3 kilograms. This is a slide I borrowed from Professor Archery, and I think it just makes the point that, as you can see in pediatrics, and certainly in pediatric HIV medicine, there's this kind of gradual movement down from adolescents, adults to children to infants, term newborns, preterm newborns, of the various drugs. And you can see that abacavir now has evidence down to birth. Zidovudine, we've had for a long time evidence because it was used in the early days and also for prevention, right down into the preterm period. Lamivudine down to 32 weeks gestational age, and then various other agents, dolutegravir, the key drug, under investigation in the neonatal period, but currently 3 kilograms and 4 weeks is our kind of start point. And so forth with the other drugs. Lopinavir, tonavir, people will be familiar, perhaps those of you who are already involved in treatment, is that we can only, strictly speaking, use from 42 weeks corrected gestational age and 14 days of chronological age, and that's been a limitation of its use in the neonatal period. We often do use off-label as in other areas of pediatrics, and we extrapolate data as best we can from adults and children and infants down into the neonatal period. So what is the sort of status quo? And when I say current, I mean sort of old, but this is unfortunately still current in many settings, including sometimes in our clinic, but certainly in I think many settings around the country. And that is pediatric ARV is characterized by treating with individual drug formulations. These are mostly liquids, or have been, with large volumes, bad taste, in particular the protease inhibitors, which leads to poor tolerance of them. And practically that leads to refusal of medication, spitting, vomiting, a very conflictual relationship sometimes between the caregiver administering the medications and the child. Often twice a day dosing, adverse effects, part of which are related to the tolerance, but also systemic adverse effects, expense, difficult storing of the medication. So this is really where we come from. Where are we going? We're going to, at least with this iteration of the guidelines, and there's always more to come in future with HIV, it's a fast-moving field. But for now, we're looking at introducing on a very wide scale the use of dispersible, scored, small combination tablets or capsules that contain granules or powder for dispersion in water or food. So that's the kind of new current era that we want to be moving into. Better taste, once daily dosing, mostly more effective drugs. And I won't go into all the virological reasons for that, but better, higher thresholds towards resistance, more effective and rapid reduction of viral load, safer drugs, easier to store for hospitals and for parents, cheaper. So multiple advantages. What do these look like? Well, this is what the current situation looks like for many of us in the field and many parents and pharmacists. So here's the 2013 ARV dose chart. You can see that these are just examples. This is taking the drug abacavir, the liquid with a syringe and the mark for dose, the possibility of the 60 milligram tablets once you get to that point on the dose chart. Eventually, we've got 300 milligram abacavir tablets, and finally, you might get to a combination of abacavir and 3TC big tablet. You got to be really good at swallowing that one. If you look at lopinavir, ritonavir, and I haven't shown lamivudine here, but it's fairly similar to abacavir. But lopinavir, ritonavir, our old friend and foe, Kaletra, down there in the bottle, it saves our bacon often, but it causes such chaos and distress and difficulty with children, young infants having to swallow it. Lots of alcohol, lots of bad taste, lots of spitting and regurgitation for many young children. A syringe and a marker. The next step from there is an Illuvia tablet, the pediatric Illuvia or the adult Illuvia, which you can't break or crush or chew. We have, since this slide, had the insertion of lopinavir ritonavir capsules, the 40/10 milligram capsules, which you can open, put on a small amount of food and ingest immediately. They weren't perhaps the sort of lifesaver, get out of jail card for Kaletra as much as we hoped they would be, because often the taste masking didn't happen and they were quite challenging to use for parents. But that's what many children sit on and go home with from clinic and from ward as well. This is what we're hoping to be moving towards, and in fact instituting. At the top you see the abacavir plus the imivudine 120/60 milligram dispersible scored tablet. It's available now. It's been on tender for a while. It's on the dose chart. It should be available in your clinic, in your provincial ARV depot. And what we are desperately waiting to have in our pharmacy, on our shelves, it's registered by SAHPRA since June of 2022, is the dolutegravir 10 milligram dispersible tablet. There are 2 suppliers. It's small, it's scored, it disperses, and it tastes good. We have to be nimble on our feet. So yesterday I merrily changed patient from abacavir and imivudine liquids or separate formulations to this combination, as I do every day when I work in the clinic, because there's no reason really in almost all patients not to do that. It is generally well tolerated, and it gets you from 2 separate formulations to 1 formulation, but only to receive a phone call from the pharmacy telling me that they were out of stock of this currently, which filled me with dread and meant that I had to go back to our horrible old friends over here and dose it separately. So you really have to be closely liaising with your suppliers, with your pharmacists, to know how to move when stock issues arise. This is the other formulation that I mentioned, this incredible formulation that was developed through the Drugs for Neglected Diseases Initiative in combination with CIPLA, working together with them. And who would have imagined that we one step ahead of the adults who have a 3-in-1 TLD. Now we've got a 4-in-1 capsule with powder being put onto a small amount of food or water. Tastes like strawberry ice cream, we hear. We haven't yet had it in our clinic, but it is registered. It's being brought into the country, and we think this is going to play quite an important role for those children who are really battling with Kaletra and lopinavir ritonavir, but can't, for whatever reason, yet move to dolutegravir regimens. This is the dose chart, and I want to just spend a couple of minutes on this to show people how you do this in the clinic. Many people who are already prescribers will be familiar with previous versions of this. This is the 2022/2023 version. You can get it from the HIV Clinicians Society website. You can get it from the Medicines Information Center website, including on an app. And it really tries to move the needle from using the single drugs to here the abacavir-lamivudine combination formulation, and get away from these combinations, which we still occasionally need, but are moving away from, and then the dolutegravir formulations over here of the dispersible tablet, which you should have hopefully in the next few weeks or months in your clinics. When you're on rifampicin, you need to add an extra dose 12 hours later, so it becomes BD, like we're familiar with lopinavir ritonavir, the green column, the boosting with ritonavir. And here's the 4-in-1 formulation that sits in that space. Twice daily dosing. You'll see it does involve quite a few capsules as you move up the weight bands, and we'll see, how well this gets implemented and is accepted by children and their families. The neonatal regimens for the older term babies are placed up there, and some guidance on practical advice on dosing over there. Just to mention that in that national guideline document, that new guideline is in there, the dosing chart. They've elected to change the order slightly, thinking that abacavir, lamivudine, and dolutegravir, the first columns, will be the most important for the majority of children on treatment in our age category of 4 weeks up to 10 years. So just don't be put off that that's a separate chart. Here's just an example of what it sort of looks like in the weight bands, with number of dolutegravir tablets, 1.5, 2, 2.5, Abacavir 3TC tablets and how you mix them together, and some guidance on administering them. So there's been materials produced to support this for counsellors, clinicians, and pharmacists to help with. Time is short, but what I would like to say to you is it's not business as usual. So, seeing a child in the clinic who's doing well, who's virally suppressed, continue, and we'll see you in 3 months, shouldn't be the case. The question in your mind as a clinician, as a prescriber, as a pharmacist, as a counselor, even as a parent, is can we simplify this regimen with new available formulations in careful discussion of what's going to be feasible and practical for that caregiver and that child. In terms of the guidelines, so what I'm saying is when you get back results, don't carry on as usual. Try and improve. Move away from individual, move away from twice daily. There are then all the children who are on treatment who are eligible for switches to dolutegravir containing regimens, and it's been divided into non-viral load dependent regimen switches and viral load dependent regimen switches. So just in very brief to say that all individuals, this is adults and children, adolescents who are on NNRTI based regimens, that's efavirenz mostly, and children who are on PI based regimens for less than 2 years are eligible to switch to the abacavir 3TC dolutegravir regimen, or to TRD if they're eligible. But for children who are on PI-based regimens for more than 2 years, whose viral load is more than 1,000 on 2 occasions, and they assessed to be adherent, those children may in fact be eligible for resistance testing to identify PI resistance, particular, and to know whether darunavir is going to be an option for future regimens. So this is an algorithm that guides that. You can see that 4-in-1 sits there in those patients who seem to be failing therapy but are also non-adherent, and whether they would be able to tolerate that 4-in-1 capsule and get them down the green channel to abacavir 3TC and dolutegravir. So last slide or two are really about just treatment literacy, which we tend to think of as directed at patients and perhaps parents and children, but really there's treatment literacy to healthcare providers and pharmacists and counselors to make themselves aware of the new changes and promote the uptake and use of these formulations on a day-to-day, patient-by-patient basis. Have you heard a new and improved ARV for young children living with HIV is available? Put this up in your waiting room, in your clinics, and on social media. There's a fantastic video that produced through the Clinton Health Access Initiative that talks through how this family arrives at the clinic and says, we'd like to know when the new formulations are available. Where can we get them, please? And that's called treatment literacy and treatment advocacy. So thanks very much to HIV clinicians, to SAPA, to the Medicines Information Center, the National HIV Hotline, who helped put together the dosing charts, the National Department of Health, who tirelessly, especially Jeanette Vessels, update guidelines. Thanks very much, everybody.